As we get ready for the panel, Dr. Humphreys will be coming up. We're going to play a short video that's going to set the stage. It'll provide the patient perspective. This is a man who has a 100-gram prostate. He's trying to decide between 3 different options, and credit for this video goes to 3 urologists from Yale University, Drs. Brito, Tam, and Lee.
Meet Eddie, 63 years old. Fed up with life because of how often he's peeing at night, he decides to see a urologist and books an aquablation. But on his way home, he has a sudden change of heart, and suddenly, his conscience comes into play.
Alright, stop. Now before you go ahead and put this truss in your butt and let the water jet do its cut, no residual tissue as consequence.
Who are you?
I'm your best surgical option.
That's nonsense. Some tissue may be, but that flow's still crazy. Q max to the max, fire hose be blazing. Now you go robotic, get to know your Foley. Wear it for a week, hope no leak on imaging.
Yeah, but if it all goes through like it's supposed to, they're gonna put a probe where you poo. That's not right, dude. Think about it before you book with this big shot. Real surgeon's gonna operate with the robot.
F that, protect that zone, shoot that skeet. You think you wanna reach climax and dry heat? Cutting through your bladder. Are you gonna leak? Think you better leave that peritoneum naive.
Man, don't do it. He's gonna leave half the biscuit.
You're right, man. Dismiss this. We popped the biscuit.
Don't even listen to Tran, yo. He's bad for you.
You know what, Joe? I don't like your attitude.
These prostates, they block our patient's flow, yo. No more flow, it's so low.
Meet Stan, 58 years old. After his 3rd trip to the ER for acute retention, he too calls up his urologist and signs up for aquablation. And once again, his conscience comes into play.
Now listen to me. While he's probing your rear, making you bleed thick and half the gland left in there. Now you gotta get a HoLEP in another 7 years, yo.
This dude fires loads without fear. You shouldn't take his ejaculation. It's just pee.
Yo, look at these numbers. Is it a guarantee? There's a chance you're gonna skeet, but it doesn't come for free. A tissue regrows and you lose your mojo and your flow slows.
Man, ain't you ever seen the guys get stuck with pads?
No, but I've seen them dry up and turn into happy lads.
Shoot, you wanna get home late again?
Man, forget that. Peel that gland clean, dog, and sail.
Jason, can I talk like pretty please? Clear up this perception that all I do is bleed? That's old news. F what you thought of me. Meet my new friend, bladder neck cautery. Clear off some fluff, find the vessels and clean up. Catheters in, now it's cleared in Aquafina.
Speaking of which, 3 days is a lifetime. Foley out the next day? Yeah, I'll get in that line.
Talk learning curve, keep it real with me, dude. Hold up, gas real scary, make you accidentally prove.
Fortune favors the bold. See, my technique is gold. You're dependent on a robot while I finesse with full control.
Alright, let's chill, man. Both of these are dope.
Perhaps we can agree most important are patient goals.
Yeah, dude, we're homies, man. No anger today. Living up in New York City at the Bulldog debate. These prostates, they block our patient's flow, yo. No more flow, it's so low.
Meet Dr. Lee, a 34-year-old HoLEP healer. He shows up one day for a routine day of cases. He walks into the OR to perform a HoLEP and finds his patient in steep Trendelenburg.
Alright, sit down, relax, and start docking.
Nah, cut that. Just let me put the scope back in. Enter the right plane, let the adenoma take flight. Shrinking monster glands operating with no stage fright.
Well, wait, what if he don't want a stricture, though?
What? Strictures are rare and I know Jamie Cavallo.
Alright, Jason, maybe you're right slightly, but transient incontinence is very unsightly.
Okay, otherwise what then? Foley for 7 days? Incision on the bladder, is this really the craze? That's beyond whack, you gotta pull that thing day 1. You'll be crying out in pain, I'll bring you breakfast in bed, son.
What'd you say?
What, didn't think I'd remember?
Give me the scissoring on one.
Temper. Mr. R, Mr. ASP, Dr. Flo J, coming straight out in New Haven, y'all better make way. HoLEP healer's gonna heal, let's make these dudes pee.
All up in the fossa gonna get lost, you see. Y'all should give up on the basic endoscopy. Trust both of these dudes committing perjury. Come with me if you wanna see some surgery.
These prostates, they block our patient's flow, yo. No more flow, it's so low.
That was great. That was excellent. And it's going to be really hard to follow that, guys. Dr. Beaches, let me give you a beat real quick. So I think they highlighted a lot of great points that hopefully we'll be able to reinforce during our case discussion. with some data and some good discussion. So thanks again for the intermission, and thanks for having us here to talk to you guys. Again, my name is Tyler Sheetz. I'm at UC San Diego and VA San Diego. We have a group of esteemed panelists here today with us. Dr. Mitch Humphreys from Mayo Phoenix, Dr. Seth Beaches from UC San Diego, and Dr. Jonathan Berger from Balboa Naval Hospital. So thank you guys all for being here. And we have kind of a mix of cases today. We have some index cases because, as I mentioned in my last talk, there's a lot of different options for workup, a lot of different options for BPH management. So I think some index cases might be fun to share some different perspectives from different people. And then we have some maybe challenging cases or cases where the data is not really fleshed out yet to go through. So without further ado, we'll start with case number 1. We have CJ, a 64-year-old male with a history of hypertension, hyperlipidemia, arthritis. He failed his trial of tamsulosin and finasteride for 6 months due to persistent, bothersome lower urinary tract symptoms. Of note, he's not sexually active, not interested in future fertility. So I'm wondering if maybe Dr. Berger, if you want any additional workup for this gentleman.
Sure, thanks. I know there's a bare minimum the guidelines kind of say we could get away with, but generally I want to know their Euroflow, PVR, a recent PSA if they haven't had one. I don't see it on there. IPSS score, yeah.
IPSS, Euroflow, PVR. Dr. Beaches, would you add anything?
I think that's a good initial workup. And then obviously if they're coming to our office to consider a surgical procedure, then we would consider a cystoscopy and some form of imaging for prostate sizing.
Gotcha. So this is his workup. We kind of got the kitchen sink here of workup. So his PVR is 100, Euroflow is down here. He has the intermittent and staccato curve with a Qmax of 6. Prostate volume we measured with truss, 73 cc's. His PSA is 5.8 with a low density. And we did a cystoscopy that showed some mild trabeculation, moderately obstructive lateral lobes, small median lobe, and the prostatic urethral length of 4.5 centimeters. So, to review, this is a patient who has failed Flomax and finasteride. He has a full workup. So maybe Dr. Humphreys, what would you counsel him on next regarding surgery or further medical therapy?
Yeah, so I think it really comes down to the risk-benefit conversation with the patient because we have so many things. And with this size prostate, you could do pretty much anything with it, right? There's nothing wrong with a good TURP. I mean, he could do resume. He's not interested in sexual function. You could consider adding 5-alpha reductase inhibitor, Cialis, for him if he wanted to try additional medical therapy. But, so this is right in line with that medium-sized prostate where he's got all the options. I would say his Qmax is pretty miserable. Men that are only peeing 6 cc's a second, even with a residual of 100, those symptoms typically get worse at nighttime. So most of these men, their biggest complaint is nocturia and figuring out what they're going to do at night. So I would advocate with him, if he wants to get off of the medications, that he consider a surgical option, and he's got a lot to choose from.
Great. Dr. Berger?
I was just gonna say I agree, and there's so many options that I just use handouts at this point where I will go over them briefly, but there's no decision making the first visit, and I make sure they've read everything because I don't want them to come back later after they've had something and have some regret that they didn't know, quote unquote, know about something. So I use the patient foundation printout for pretty much everybody.
What would be your go-to surgical option for him, you think?
So that means after a discussion,
Yeah.
I would say,
Really pretty undifferentiated.
yeah, I mean, the easiest one, the quickest one that works on almost everyone for me is a TURP. You get it done, and it almost doesn't matter what you run into. I would
Do
say,
you have a maximum size for a TURP that you would? in your head?
Somewhere around 100.
Somewhere around 100.
I would stop offering it with some exceptions. It might not be my go-to as you approach 100. I would say even with the PSA density explaining his PSA of 5.8, I generally do chase that down with at least an MRI before just going straight to a BPH surgery because there may be a biopsy.
Yeah, that was actually my next question.
Sorry. Yeah, I take it back. I'll wait for you.
No, I actually forgot about it. So, yeah, I agree with you. An MRI guy of prostate cancer screening age would be helpful. Dr. Beaches, any insights onto what your go-to management
Yeah,
would be?
I was going to say this is like the classic juicy case that has so many different options. And I think to highlight what's been said, really engaging the patient in a informed decision so that they understand the pros and cons and that their expectations are aligned. Because I think the worst thing you could do is offer a procedure that they aren't, if they have a side effect that they're not anticipating or wasn't in line with their perspective, that can be the most challenging part of these cases is dealing with the post-operative. So I think if anything that you do, if you're comfortable with it, if you have certain outcomes that the patient's expectations are aligned. So for example, this could be a great HoLEP case. This could be a great, resume case. I think to contrast those, resume, for example, would, take 2 to 3 months to see an improvement in symptoms. Whereas something like a HoLEP or an outlet obstruction, you'll have an instantaneous improvement when that catheter comes out. And you may or may not have some overactive symptoms along the way. So I think counseling the patient to be prepared for those things is most valuable.
Dr. Humphreys, you mentioned an interesting point that I think is a challenge to a lot of BPH surgeons, and that is the symptom of nocturia. So say hypothetically this patient's most bothersome symptom was nocturia, and maybe their Qmax was normal. How do you go about managing these patients with, maybe moderately sized prostates whose most bothersome symptom is nocturia?
Yeah. So I'll be honest, in my practice, the majority of these patients end up with a HoLEP. They don't usually find me by mistake. And so the thing that I tell them about nocturia, and I think one of the concepts that we're learning in BPH is a lot of times we allow these symptoms to progress until their bladders almost become end stage. And I think nocturia is one of those early symptoms where we have a chance for early intervention to preserve detrusor function, to prevent end stage bladders. I think that's one of the most early bothersome symptoms that we need to key into, because a lot of men say, well, I'm getting older, so I'm getting up more at night. And you explain to them, well, if you wake yourself up at night, you're going to pee as well as you do during the day, but you're going to have a harder time going back to sleep. And so the more we decrease that outlet resistance, the less pressure the bladder has to make, the easier they empty the bladder. So we start, of course, with lifestyle modifications, all of those kind of things, but we move pretty early to surgical intervention, because I believe early surgical intervention not only prevents end-stage bladder dysfunction, but it also gets away from those medications and lifetime of medications and polypharmacy and some of those other things. And so if you can pick some of those options with low retreatment rates, it actually serves the patient, and I would almost argue the health system better in terms of allocation of resources.
And just one point to that on nocturia, I think one thing to differentiate too, especially in the common scenario I see is an elderly patient in their late 70s or 80s who presents with isolated nocturia. And I think you just have to be careful in that. If their true symptom is isolated nocturia, then just making sure we've done an evaluation for things like obstructive sleep apnea and other medical causes. A lot of times they'll have nocturia and they'll say they have no symptoms during the day until you do avoiding diarrhea, and then you realize they are having frequency and prostate-related symptoms, and then that'll justify it. I think for me, setting that expectation too, that if you are getting up 5 times at night, you're probably not going to get down to 0 for an 80-year-old, but you will have an improvement in your symptoms. You'll sleep.
Actually, to that point, if you look at the studies, nocturia is the most predictive of overall death. And it's not because nocturia causes death, but it's a reflection of cardiac status, lower extremity edema, mobilizing fluids at night, cardiac dysfunction. So nocturia is an important thing as a urologist to key in on.
Dr. Humphries, do you find that most of your patients, their nocturia improves after HoLEP?
Yes.
Yes. So, this probably depends a little bit on the surgical modality, weaning meds after surgery. Maybe for Dr. Humphries, how would you wean this patient's meds after HoLEP? Do you stop it outright? Do you continue them until the first follow-up?
No, I have them stop immediately. They don't need the medications anymore. We stop immediately, unless, you don't see any old alpha blockers and those things anymore. I mean, everybody's on the super selective, so you don't have to worry about the weaning that we used to have to do 10, 15 years ago.
Sure. Dr. Beaches, after a resume, would you do the same thing, or would you wait till the catheter comes out?
So for something like a resume where they have a more delayed improvement in their urinary symptoms, I do continue their medications until the first follow-up visit, which is generally 6 to 8 weeks for me. I just find that occasionally, once the catheter comes out, some of them do complain of more urgency and inflammatory related symptoms and weaker streams. So keeping the medicines going until we get to that point at 1 to 2 months where we know they'll have their maximum improvement in symptoms.
That makes sense. Dr. Berger, any changes after a TURP for weaning meds?
Yeah, it's completely dependent on the procedure. For when I do an enucleation, I agree to stop them right away. Resume, I actually leave them on for like 3 months, all nervous with it. And then the ones that are all in between, or TURP, I guess, is the main one in between. Usually it's their first refill, to be honest, because I forget that follow-up, and then they call for a refill. I actually don't need that anymore. So somewhere, a month or 2 is where it ends up being. First follow-up, if I remember to tell them to stop it, though. I don't stop it at the time of the case.
Okay, some good discussion. Thank you, guys. So I had some kind of alternative cases or offshoots of this case. So let's talk about what if same case, 73-gram prostate, 64-year-old guy, moderate symptoms. Say you're doing a surgery and he was on blood thinners. So let's say maybe baby aspirin. Raise your hand if you would do the BPH procedure on baby aspirin. Okay. Raise your hand if you would do it on Xarelto or Eliquis actively. Okay. Raise your hand if you would do it on Plavix. Okay, so 2 out of 3. Ideally, you're weaning these blood thinners before surgery in consultation with your anesthesiologist and cardiologist. Do you have so I find that every institution has their own way of recommending when to stop anticoagulation, but when to restart anticoagulation, such as Eliquis or Xarelto, that's a little bit more of a gray area. I found not a lot of data about it. So interested in kind of your guys' perspectives about when you would restart a full anticoagulation after a BPH procedure. And I understand it's procedure dependent, but any insights?
Yeah. So when I raise my hand with Plavix, please take that with a grain of salt. Plavix is nobody's friend but the cardiologist. But if they've got a mechanical heart valve or something like that, and the situation arises, there's ways to work around that. For me, when I restart them on blood thinners, I like the Eliquis because, right, it's reversible. So it's unlike Plavix. Plavix, I wait longer to restart that to make sure we don't run into problems. I may bridge them with a different antiplatelet agent or different blood thinner during that time to be safe. But I generally say, depending on why they're on it, because there's a difference in AFib versus artificial valve, right? Those are two totally different patient populations with different impetus. So I take a little bit of a page from the literature, actually, from the cancer and the bladder cancer, and putting patients on antiplatelet therapy after major pelvic surgery, and it's shown to be okay with minimal blood bleeding situation. So I tell them, look, in 3 days, restart your Eliquis. If your urine's not clear, if it gets redder, stop it after 1 dose, and then currently go back up. I never have patients start with.
Sorry to interrupt you. If their urine is still bloody at 3 days, should they still start it?
Depending on bloody, I tell them, can you see through it? Yes. If it's red, dark, if you're passing clots, no. And then I say, really restrict your activity in those kind of things. So I really use the patient and the situation as my barometer, but I tell them to go slow because we don't want to be back pulling clots out in the middle of the night and those kind of things.
Makes sense.
I would say for TURPs and HoLEPs, when I get to the equipment to get back to doing them, I usually don't take out the catheter before they leave. Have them come back in a few days to do it in the clinic, and that would be the timing when we make the decision. But otherwise, it's similar to what Dr. Humphries says. This patient's prostate is a little small for a simple prostatectomy, but I would sometimes consider it on these individuals because I do a 360 mucosal advancement, and I send them home the same day. Actually, they're obviously going to have their catheter in a little longer because of the cystotomy, but it feels better controlling the bleeding when I'm actually cauterizing it and then oversewing it and then putting mucosa on top of it. Feel more comfortable with knowing, that's safe to restart some of these blood thinners. And again, yes, condition dependent. Are they on it for a valve or are they on it for AFib?
Makes sense.
It's funny because I used to do a large volume of green light procedures, and per the guidelines, green light or HoLEP would be things to consider if someone's on active anticoagulation. I think the reality though is whatever procedure you're comfortable with that gives you a good hemostasis. So if you can get good hemostasis from a TURP, for example, versus a green light, I'm not sure. I think whatever will give you the best hemostasis moving forward. So for example, a green light, if I'm really concerned with someone, I'll actually use the bipolar loop at the end for cautery if it's someone who really can't come off of a blood thinner. But I always, for the question of Eliquis and Xarelto, again, depending on the indication, if it's AFib, but I usually propose to the cardiologist the idea of a week and see how they respond. And I just say, can we hold this for 2 days pre-op and 5 days post-op and give them a 1 week? And sometimes the cardiologist doesn't think twice about it, and then sometimes they get concerned. And so that's how I can also gauge how severe is the indication that they need to be on it.
Makes sense. Good discussion. So, talking a little bit about antibiotic therapy, preoperative antibiotics, postoperative antibiotics. Say this patient had a history of recurrent UTIs or prostatitis. Dr. Humphries, what's your standard algorithm for preoperative and postoperative antibiotics? And does that change if patients have a history of infection?
Yeah. So first of all, a lot of these men with prostatitis come in and think that this surgery is going to make their prostatitis go away. And so I level set that expectation that yes, it may, but we're not removing all of your prostate. You may still get prostatitis after this, right? So I obviously use specific antibiotics. And what I like to do, especially if it's a big prostate, what we found is sometimes these antibiotics actually have anti-proliferative effects in terms of VEGF. And so they may have less blood vessels. And so when I put them on antibiotics beforehand, we see less bleeding. And we've got some data to show this. So those patients that have had a foreign body in their bladder, whether it's a Foley catheter, self-intermittent catheterization, I look to put them on preoperative antibiotics for about 10 days, culture specific. If they haven't, then I put them on 5 days. And what we showed in our data when we looked at this is those that were on antibiotics for whatever reason had less bleeding. And we think it's because of the proliferation of the endothelial factors and the way that antibiotics reduce that inflammation and that neovascularity. And so we've actually found that to be pretty useful as an adjunct for us.
Very interesting.
So I think in the interest of time, I think we may start thinking about wrapping up.
Sure. We've got about 6 minutes left, it looks like. Oh, really? 2 to 3. Okay. All right. If the patient has a concurrent bladder stone, how would that change which procedure you offer them? Maybe Dr. Berger?
I don't think so. You can do transurethral. You can put in a offset, smaller offset nephroscope and use a lithotripter through there. If they're interested in a transurethral procedure. If we're doing a robotic simple, then just take out the stone that way. So I wouldn't affect whichever the patient wanted, we can make it happen.
Dr. Beaches, how about for resume? How would you manage a bladder stone if the patient wanted to resume?
I think similarly, I would, offer a cystolitholepaxy perhaps with a laser at the time.
What if the patient was a high-profile lawyer and they had an international flight to catch 1 week post-op and they really wanted surgery beforehand? Is there any modality that comes to your mind that you would offer them over another, or would you say we need to postpone your surgery?
I would still offer him a HoLEP.
Okay,
Catheter comes out the same day. They go home the same day,
sounds good.
as long as he's not lifting heavy suitcases.
I would offer him whatever. I would just tell him I don't think it's a good idea to go, and that's against medical advice, but he wants to do it.
Yeah, I would have them avoid traveling for a couple of weeks just for that very rare risk of bleeding. Or if they really needed to catch a flight, I usually would have them go out to Arizona and see Dr. Humphreys.
Any insights on the opposite end of the spectrum if a patient has a difficult social situation? Any changes in your perioperative management or what you may offer?
I think this is a great example where having perhaps a 23-hour stay with catheter removal or to discharge could be valuable, just because if you're concerned they don't have the ability to come back to clinic.
I also think this is an opportunity to be more definitive. This is where I'd actually steer away from the missed procedures, because typically we know there's a certain failure of those. We know there's a certain medication rate on those. So I'd be steering this patient to more of a definitive solution for their outlet rather than thinking about resume or urolift or any of those.
Yeah, I may also think about offering them something where we could get any tubes out before they leave the hospital too, I would say. So, great discussion points. I think we're running out of time. I don't know if we have time for any questions or comments from the audience, but appreciate you for listening.